Thank you all for joining us. My name is Cindy Pankella, and I am the Director of Practice Management and Education at the American Osteopathic Association. Before we get started, I want to give you a little housekeeping. You have any questions during the presentation, please type them into the Q&A box, and our speaker will answer as many as she can at the end of the presentation. Also, reminders that you will be able to get a copy of these slides. They will be posted, as well as the recording. They will be posted tomorrow. And so our presentation tonight is called Get Paid for Telehealth, the New Rules for Documentation and Technology. Our speaker today is Jill Young, and Jill is a certified evaluation and management coder, a certified professional coder, a certified emergency department coder, a certified internal medicine coder, and the principal of Young Medical Consulting, LLC, a company founded years ago to meet the education and compliance needs of physicians and their staff. She has over 35 years of medical experience working in all areas of the medical practice, including clinical, billing, and rounding with physicians. Her unique style of working with physicians is not only effective, but helps bridge the gap between coders and physicians from a practical perspective. Her comments and opinions can be seen in several publications and also heard on a variety of audio conferences. Her background gives her a unique style of teaching using real-life examples of coding and billing situations. She hates boring lectures, so be prepared for a presentation that is fast-paced and informative. And so sit back, take notes, and be prepared to ask your questions, and we'll answer them at the end. Jill, it's all yours.
Thank you so much, and good evening to everyone who is listening in. Just one more housekeeping item. If you have a question and it regards to a specific slide, if you can write that slide number down so that if needed we can flip back there, that's always helpful. So let's get started. The information in this lecture is as reasonably up to date as it can be as of yesterday, when I put the finishing touches on it. And as you all know better than anybody else, this information is, I don't want to use the phrase constantly changing, but it is changing and evolving daily. I said to Cynthia at the beginning, if they could just give us 3 days without announcing anything new, it would be so much easier. But a lot of what they're announcing now, especially from Medicare CMS's perspective, is they're clarifying things. Once we got the big glut of information on the 30th of March, we're trying to digest it and now put it into more practical application from the coding and billing world. But we need to get good information out to our providers. One of the things that I think we'll always remember is that March 6th date, when things started to really change. But what you'll hear referenced a lot is the 1135 waiver. And that was the document that was signed into being by the president that in essence changed the Social Security Act, or the Act, which is what we take our direction for from Medicare. If we talk about telemedicine and telehealth, and I've been talking about them for several months prior to COVID-19, a lot of organizations use the words telemedicine and telehealth interchangeably. And that has, prior to this, was just an annoyance, but now it's become confusing to a lot of people because the words are used interchangeably and they're not intended to be, in my opinion. And so you're going to put that in the back of your brain to remember that telemedicine is more the practice of using technology. Telemedicine is what I think of when I think of Medicare and HIPAA shortage areas and audiovisual calls to patients that are at a rural hospital somewhere. Whereas telehealth is more that 30,000-foot view of the telecommunication and the technologies that support healthcare that are done at a different level. So one is more of a concept, one is more of a practical application. Now, we've had several acts that have been signed into law, several phrases that we see over and over again. One of the ones we see is the PHE, the public health emergency, and that is usually referenced in things will come to a close as that is declared as ending. We have the document that was released on the 30th, the CMS 1744 document, and that is something that, from my perspective, is clarifying so many things that we were hearing about is happening. And it's been called the final rule when it comes to the COVID-19 policies that we see in place. Just trying to give you some of the background that we have. Now, telemedicine prior to March 1st was something that had an originating site where we had the patient was there. They were usually in what was called this HIPAA shortage area. And then we had the originating site, which is where our providers were. And so the provider would be in communication with another location and give care to patients. That originating site where the patient was would actually bill for services. And I'm mentioning this for a specific reason. What we've seen is that they have waived the originating site restrictions, and so they don't have to be in a shortage area, they don't have to be in a specific location. The patient can be anywhere. The patient can be at home, they can be in a care home, a nursing home, they can be in their daughter's home. That location was, the location restriction was removed in order to let patients stay where they were in order to receive this type of care, to keep them safe, to keep them from being exposed. So we have our list of providers that can do these services. And the reason that I mentioned that payment is one of the things your staff is struggling with is we were told, okay, we're going to bill telemedicine services, and that's place of service 02. There was a very specific place of service that was created for telemedicine services. So they would bill the 99213 with the place of service 02, as opposed to place of service 11, which is your office. And unfortunately, what happened is you received less money because built into the electronics of processing that claim was money to pay that originating site where the patient was. So what we were told to do, no one had thought through the ramifications of it. And as you can see, you got 0.72 of an RVU less money. Whereas now they're telling us to do it differently. They're telling us to bill it at the place of service that you would usually perform the service at, which for most of our clinicians is office, and then attach a modifier that says, okay, this is a service that was done with that synchronous telemedicine. So from the get-go, we made some assumptions based on what we always did with our telemedicine services, and those assumptions and directions that we were given were incorrect and resulted potentially in a decrease in payment. So that's why we were scrambling to get that good information out to our providers as fast as we could. So if we take a step back and look at that final rule defined, if you will, our telemedicine services as this interactive telecommunication, meaning we have at a minimum audio and video equipment. Audio and video are required when we talk about providing that service, and I call it telemedicine service, where you're going to bill office visit codes. Now, one of the things that has been relaxed is also how you can talk to those patients. We can see, and let me just pull the next slide up, they tell us that you can use not only, let me get a pointer here, we can use FaceTime and Skype. We can also use some of these programs that I've never heard of. And then there's a list of ones that we cannot use, which I've never heard of, TikTok or Twitch. But they gave us a list, in essence, saying if you're acting in good faith and you have a program that is what they call non-public facing, meaning it's a platform that is not intended to be shared with people outside of the two that are communicating, then that's okay. So that means that you can call from your phone and FaceTime a patient, you can use Snapchat or anything. But also remember, if you will, non-public facing also is a reminder for HIPAA. if you have two doctors sitting in an office, they shouldn't both be talking on their smartphones at the same time, FaceTiming patients, because not only of a possible bleed over in conversation, but also because of the possible exposure of the image on the phone to the other phone. So be careful, use common sense when you're making those calls to patients. And I certainly will stop and say, I understand that if we're talking Medicare patients, and if you look in this bottom left-hand corner, these slides have cms.gov on them because they're information from Medicare. We're talking Medicare patients, and I know my mom has a phone that she can do FaceTime if someone's sitting beside her and shows her how to do it. But in this environment where most of us are quarantined, it's not possible, and that has created some major problems for our providers in that this kind of service is hard for them to perform. But let's talk about if you can perform it. They have relaxed that new patients are allowed in this. We have patient's consent that needs to be followed, but the good news is that the patient's consent, the auxiliary staff can take and document that consent under general supervision. That consent, some codes want it annually, some codes want it every time you do the service. So my suggestion is just have your staff get consent each time that you're doing this service, have them documented in the record, and then you don't have to worry, is this one that needed it once a year or twice a year or every quarter, whatever, so that you can just, deal with it as you need to. The patient's financial liability was something else that changed. Now, they didn't say that they would waive their deductibles and copays. What they did say was that you can waive them if you want to, and they won't get you and you won't be in trouble for doing that. Now, I did just see something tonight that indicated there may be some waivers if it's specific to the COVID-19 testing. That information just came out. So if you see something that may be part of what we would see, that they would be allowing for Medicare to waive themselves the copays and deductibles, but that's just for the COVID-19 testing. That's not for these type of telemedicine visits. Just on a note, in all of this, HHS also said that for other patients that have our high deductible coverage plans, that if the health insurance companies or you decide to make a waiver of copays and deductibles, you're not going to be in violation of any of the various rules that they put in place so that you wouldn't waive copays and deductibles. There's several different modifiers that you're going to work with, but as physicians, the only ones I think that concern you is the modifier G0, which for telemedicine existed without location specific, and this is for a patient that you would be working with in the diagnosis treatment of someone going through an acute stroke episode. So what is it you're going to actually be doing if you're doing these telemedicine visits? So you're going to be calling Mrs. Smith, you're going to get her on FaceTime, let's say, and how are you going to be documenting that service? Well, if we use traditional means, you could use your time, like your counseling and coordination of care time that we see, and I've used the 99213 and 99214 in this for just for examples. Or you could use more of your traditional elements using 2 out of 3 for existing patients, where you would use your history and your medical decision making. And so there's the requirements for the 99213, and there's the requirements for the 99214. Again, just informational for you. And you've all probably seen this grid when it comes to looking at how do you get to your medical decision making, which becomes important because what we have seen only for office visits, only for these telemedicine office visits, they are jumping in part to the 2021 documentation rules. And so what they're saying is that the E&M level selection for services can be based only on time or only on medical decision making. They've removed the requirements regarding documentation of history and or physical exam. Doesn't mean you can't do it, it just means it's not required in the documentation. Now, this is a policy revision, it's on an interim basis, but it's similar to the policy that would go into effect in 2021. I say similar because that has a different medical decision-making table of risk that they work with, and there's a few other tweaks. So now let's go back and say, okay, if I'm going to be documenting a telemedicine visit and I only need to document medical decision-making, and don't forget medical necessity. You always have to show medical necessity. So if you have a patient, for example, that's coming in that has a new problem, as the red arrow shows, that's going to be 3 points. If you didn't order tests, that's okay, because remember, this medical decision-making section is 2 out of 3. We'll go to the table of risk, and now let's say that you have a patient that either is given prescription drug, you're going to give them medication for this new problem that they're having, or perhaps you have a problem that has a couple of existing stable chronic problems, and here you can see with the red arrow, this moderate on the table of risk is for 2 or more stable illnesses. Why am I saying this? All of this leads us to this medical decision-making table that tells us what's a 99213 and what's a 99214. These cut and pastes are from an auditing sheet that you can, if you just type in, audit sheet on the internet or HGSA, they would give that, you'd come up with a form much like this. But this is what you're doing every day anyhow. You're just, if you think about your medical decision-making, all they're doing is saying you don't have to document at the level in the history or exam that you are used to, and they're trying to make it easier for you. The other thing you could do is base it on time. Now, this is a new definition of time. Again, we're talking 2021 modified rules. That time is defined as the time that the reporting provider, no one else's time, the reporting provider spends not only face-to-face with the patient, doing that FaceTime or Snapchat or Skype, but also non-face-to-face time with regard to that appointment. Now, it's on that day. So let's say you're getting ready to call Mrs. Smith and you get her chart out and you do some review of that chart, and then you pick up the phone and you try to call her. You finally get her on the phone, whatever. From the start of when you started that encounter in looking in her chart until you hang up the phone and finish your documentation, that non-face-to-face time counts. Now, this is only for telemedicine, and it's only during this crisis. But again, this is to me, it's a big change, if you will. It's the change we would see in 2021, so this is a little taste of what we've got coming down the pike. If we're talking about time in general, any of our codes that have time associated with them, any of the codes we'll talk about in a little bit, are codes that you have to meet or exceed the minimum time for the code. Now, that's not the counseling, coordination, and care time we were just talking about. This is different. This is just in general when we get to the telephone call times and the store and forward times, just to put it in here that you have to not only go the minimum amount of time listed for the code that you're going to bill, but you have to document that you've met that minimum threshold of time. Just last week, they added all of these services to telemedicine. And there is, I believe, a link that you can go to and see all of the CPT codes that are eligible for telemedicine type services. In the hospital previously, you were only allowed to see patients once every 3 days. That has been waived. Nursing home restrictions have also been waived. Prescriptions, especially our Schedule 2 through 5, had some restrictions previously, and now they are lifting those restrictions and saying if you've not conducted that in-person medical evaluation, but you meet all of these conditions, then you are allowed to write that prescription. Now there's some, and I try to give you more information rather than less, and again, as Cynthia said, you'll be able to get a copy of this later. Licensure is something else we're working with. Previously, for telemedicine, telehealth services, you had to be licensed both in the state that you were in, but in the state that the patient was in. They have waived that requirement. So if the patient has moved to their daughter's home and that's in Montana, you do not have to be licensed in Montana. Now, you do still have to meet state and local requirements for what they require, but when it comes to CMS, that 1135 waiver gave you permission when it comes to the telemedicine services to not be licensed in the state that the patient is. And then just a reminder of what all you generally need to have for these services, making sure those conditions are normally met, where we have them enrolled in the Medicare program, they have a valid license in the state. Again, I'm not going to read it to you, you can read it on your own. Now, the location of the provider, and I get a lot of questions about this because a lot of providers may be working from a location not their norm. And again, this is information that we were told one thing and it has changed. I've seen on the listservs that people have called to Medicare and been given answers, but this has changed with the final rule. It's allowing for practitioners to render these services, to make these phone calls from their home without having to register their home as an office location. Basically saying, bill from the location that you're enrolled in, even though you may not be there, even though you might be in your car. You can go ahead and provide these telehealth services, telemedicine services, without having to report that address. Now, again, that's a change from what we were told 2 weeks ago. That's a change from what many of your offices called into provider enrollment at Medicare and were told that they had to register your home address. The final rule came out and dispelled that. Regarding provider enrollment, if you do have someone that is going to come and help in your practice, they have established these toll-free hotlines in order to enroll and give temporary billing privileges to people waiving the requirement for some of the screening and background checks in order to fast track these applications. So what's going to happen is your staff would call the enrollment hotline in order to initiate the process. They're going to give some specific information, and over the phone, on that phone call, they will be given, if all things line up, that provider will be given a number in temporary billing privileges. And I call that fast track. That is really fast track. Now, when the emergency is lifted, they're going to go back and say, okay, we're going to want these people to submit a real application and go through the process if they're going to continue to practice. But in an effort to get providers re-enrolled, whatever it is that it takes, they're doing it. And I think doing it over the phone is pretty expedited. We have a lot of things with telemedicine and telehealth and HIPAA. We have a lot of things that have gotten appropriately so, but we have to think about what's for the greater good. And so entities sharing protected health information with patients' families or other persons involved in their care, people that you would not normally talk to in order to treat the patient or in order to backtrack where the patient has been or whatever it is that they need to do for the greater good. These HIPAA things that they are waiving in order to say it's okay to do this. So whether you're a covered entity that's concerned about disclosing PHI, understand that pretty much all bets are off if it's for the, for the greater good of the patient or for the community. And that last statement, healthcare providers may share PHI with anyone in order to prevent or lessen a serious and imminent threat to the public health and safety. I think that kind of says it all. Now, when we look at providing care, the telemedicine, telehealth care, you would think, okay, well, we have to get the COVID-19 diagnosis in there somehow. But in writing the final rule, they said, no, these provisions are for care without regard to the diagnosis of the patient. We don't want these patients coming out of their homes. So whether they have an earache or a headache or have symptoms of the COVID virus and they want to talk to their provider, whatever the reason is that they're seeking care, then that diagnosis is what you need. We still have to have, as always, our reasonable and medically necessary documentation, but we do not have to have the COVID virus diagnosis on every single claim form. That care is not limited to that, nor does it need to be tied into that. And I think that's a big thing to make sure you hear. Now, I have a section on ICD-10 coding, and I'm a coding geek, so I get excited about these kinds of things, but I know that for you, you just want to know what codes am I supposed to be using. So effective April 1st, which means we have parts of March to work with, but effective April 1st, they have, and it's actually a temporary code that they've created. And the U section is apparently for special purposes, and this is where they've come up with 2 temporary codes. There's actually a code for vaping and a whole series of codes, but they fast-tracked the code for COVID-19, which I think they moved 2 mountains to get this done. I was on a call and listened to how many people it took in order to get these codes through the process within just a couple of weeks. So the code for COVID-19 is the U07.1, and then you're going to use an additional code to identify whatever else is going on with the patient. Now, there's some other qualifications I'm going to let you read. This particular slide is something that coders always have to remember, is that our job is not to verify if you say the patient has a positive, or if you say the patient has an illness, our job is not to look for a test that says it's positive. Our job is to code what you have written. So understand that if you write down that a patient has a positive COVID-19 test, we're going to code it as a positive patient. We also have the presumptive positives, where we have a local test that's positive, but it hasn't been verified. We're going to code those as positive tests also. So understand the power that you providers have. If you write that the patient is COVID-19 positive, it's going to be coded as such. So what we see, and what I did was I put these side by side so you could see the change that we had. So from February 20th, which is when they issued this advice originally, till March 31st, if you had a patient that had pneumonia and it was confirmed to be because of the COVID-19, you were to assign a code for viral pneumonia and then a B code for the bug, if you will. After April 1st, we actually switched the order of things, and we're going to put the COVID-19 diagnosis first and the viral pneumonia second. And then for all of the rest of these diagnoses, we see the same thing, where we have instructions that were given to us for up until March 31st, and then instructions as of April 1st when the new code became effective. And again, you'll have a copy of these in the presentation you can get tomorrow. Also, you can go to the CDC website. You can see that logo in the bottom corner. If you put into your search box CDC and then ICD-10, it will come up and you'll be able to see the documents that this information came from. They're just a couple pages. They did not have screening codes prior to April 1st or screening instructions or in asymptomatic patients. So that's why those were blank. But in the end, if you had a patient that came in that did not have a definitive diagnosis, all they had were signs and symptoms, then as always is the case with your coding, if you don't have a definitive diagnosis, you code the signs and symptoms that you have. And so those are the instructions that we were given, have been given for coding prior to the April 1st release of the new code and after. And then there's a little twist on it for pregnancy coding. And then just remember that we do not, as coders, we don't code unless the doctor says the patient has it. So if you say you're pretty sure they have it, that's not definite to me. If you say it looks like it, no, that's still not definite. You know, it's the old rule out. Suspected or possible, we're going to code our signs and symptoms. So understand how powerful your words are. So we talked about the telemedicine services where you're going to do an audio-visual phone call to a patient and you're going to bill your traditional office visits. Now let's talk about the rest of the care codes that are out there. We have our electronic care codes, telephonic, and then our telephone and visual, which are the ones we just talked about. So let's look at the electronic ones first and understand that we have codes for both our physicians and other qualified healthcare professionals. So those are our NPs and PAs, certified nurse specialists. And what we're going to see is we also have codes for some other qualified healthcare professionals, but they're going to mirror each other in that the codes all read up to 7 days of cumulative time for this online digital evaluation and management service. So 7 days, a total time of 5 to 10 minutes, 11 to 20 or 21 or more. And these are the codes I said you have to meet or exceed the minimum threshold. So these are the codes for online for our physicians and NPs and PAs. There are some details that go along with each of these codes. Patient-initiated services, and I'll talk more about that in a moment. These are codes that require verbal consent annually. Remember, I said let's just get it every time. It's something your staff can do. Now, in the code descriptor from CPT, it says this is not for scheduling of appointments or communicating test results or anything that doesn't really require something like an E&M service. And you're going to have documentation of the encounter in your chart, and our clinical staff time is not included in total time. Your clinical and auxiliary staff, ancillary staff time is not included in any of these codes. Any of these codes that are time-based, it is only provider time, and it's the provider of service time. So that cumulative time starts, once you look at what are you going to, whether it's coming through a portal, whether it's coming via email, what is it I'm looking at, and all subsequent communication that you have, and notice it's a subsequent communication with the patient through online, telephone, email, or other digitally supported E&M service. So anything with regard to that initial email or portal communication that came to you is going to be included and need to be included in that time. The digital evaluation for our non-physician healthcare, these are clinicians that don't have clinical or the E&M code capability within their scope of practice. So it's, as it says in CPT, like our PT, OT, speech language therapy, and our clinical psychologists. You can see the code reads exactly the same as the other code, and the time elements are the same. We also have this remote evaluation, our store and forward. It's a G code for Medicare, or that Medicare has created. And this is an unusual code because it doesn't kind of fit in any one place. But this is where the patient would send you a video or send you images. Now, as we see with our next set of codes, it can't have anything to do with an E&M service in the prior 7 days or have anything to do with a procedure or a visit you're going to schedule in the next 24 hours or soonest available. But this is something where they're going to send an image to you. And again, we have the same kinds of qualifiers that we have with some of the other codes that we see. And so that code just kind of sits in a weird place because it's got video to it, but it's a recorded video. It's not real live time video. So now let's look at our telephone codes, and all of these have not originating from that related E&M within the prior 7 days, nor leading to an E&M or procedure in the next 24 hours or soonest available appointment. Those are the restrictors that we see. Now, the initiated by patient, and again, I get this question a lot, this was in one of the news releases saying, okay, we expect these virtual services will be initiated by the patient. Patients would contact the office regarding the need for care. So that's the best definition of initiated by patient that I can see, as opposed to the provider calling the patient and them initiating it. Now, I get questions, well, what if the patient has an appointment? Can we use that as the patient's initiated the care? I think you have to set a policy for all of this. Go through the definitions as you can find them best. That final rule document, which if Cynthia will remind me, I can put a link to that on the, we can throw a link to that so you can find that easily. But read through that, because there are some gray areas and everyone comes up with a question that addresses their own little scenario. So if your office comes up with a policy, not only will you proactively address a lot of these little things that you can go astray with because you don't have a policy, but you can also address them ahead of time and be consistent, because I think that's the most important thing in all of this, is be consistent. So here's our first set of codes. Now, I see a lot of chatter about this. These are codes that have been in existence in the CPT book, but they have not been payable by Medicare. If we look at the Medicare fee schedule, they are not listed as payable. And so people are still saying, well, how are they going to be payable if they're not listed on the fee schedule? I think those are technical things they're trying to work their way through. But the 99441 series of codes are for telephone evaluation and management services provided by a physician or other qualified healthcare professionals. So there's our NPs and PAs. This can be for a new patient or an established patient. But again, we have that restriction of not being related to something we've done within 7 days from an E&M perspective, nor leading to something else within the next 24 hours or soonest available. Notice the timelines for all of these codes. They have the same time breakout, 5 to 10, 11 to 20. And again, you have to meet the minimum threshold of the code. These are also not only non-face-to-face, but they're initiated by the patient. And that doesn't mean that we can't educate the patient that these are codes that are out there. But again, that patient calling in having a problem, or a patient that has a problem, such as that they be normally coming back in for an appointment. So again, those restrictions are spelled out on that slide. So here is the next set of codes. These are for that same exact service, but it's going to be provided by a non-physician, a qualified non-physician. So that's our PTOT, speech language therapy. And those services have the exact same verbiage as the other in that telephone evaluation and management service. And then we have the brief check-in, if you will, this virtual check-in code that just kind of came into being. This is a 5 to 10 minute discussion. Now, I get a lot of questions. What's the difference between this 5 to 10 minutes and this 5 to 10 minutes? In the final rule, they sort of said this was intended for a brief check-in, and this one has a little more substance. I don't personally see where they've given us any direction on what the difference is. But these are, we have our audio check-in possibilities. We have the verbal consent is there. We have our copays that apply, again, with the asterisk of if you choose to, write the copays off. And remember, if you say to the patient that, say you'll accept what insurance pays, don't say you'll just take what Medicare pays, because if they have a secondary, you can make sure to get those funds also. These virtual check-in codes are not telehealth, and so they don't have some of the restrictions of telehealth. That's laid out in the code, but most of those telehealth restrictions would have all been waived, so you don't have to even think about it. So these codes are just, again, some of the verbiage of how these codes were created, and it's something that you can read if you choose to. Again, I choose to give you more information than less on the codes. So probably one of the biggest questions I get from some offices has to do with supervision, whether it's supervising your auxiliary ancillary staff because you're not in the office and you told the patient to come in and get a shot of something and you're not there, or your NPs and PAs and the supervision that you would provide to them. In the final rule, it talked about that this real-time audiovisual telecommunication technology would allow for you, if needed, to observe both the patient interacting or responding, et cetera, as you can read it yourself, but basically saying, you know what, as long as you have that capability, then the fact that the provider is not on site is going to be okay during this crisis. So the presence of the physician includes that virtual presence, especially when that's done to reduce exposure to the patient, you, the provider, and you, the staff. So you are now allowed to supervise, if you will, through the availability of your smartphone and any of those other technologies that they are allowing. So previously we had said we didn't think you could do incident 2 with telehealth, but now in that they're saying we're revising the definition of direct supervision to allow for the duration of this public health emergency for the COVID pandemic, for direct supervision to be provided using real-time interactive audio and video technology. So they are removing that in the office suite that you're so used to hearing about. They're removing that requirement, and that's a big deal. Other insurances with lots of question marks, and there are lots of question marks. If you think of the variables that we've just talked about with the codes that we're dealing with, every one of those variables is a variable for any given insurance, and they can do how they choose. If we look at Medicaid, states do have some broad flexibility. They have to have certain things happen in order for them to be able to cover some of the telemedicine services differently. But for example, in the state of Michigan, they announced very early on that they were going to allow for telemedicine services to be received in the home. And then Michigan Medicaid said, as you can see by this arrow, it says during the period with dates of service referenced above, all codes on the telemedicine database will be allowed for the service delivery method telephonic only. So Michigan Medicaid said that audio only for any code on the database for telemedicine. So that would mean those 99213s and 14s could be done over the phone for Michigan Medicaid. So there's a variable that Michigan has taken a different twist on. When we look at our federally qualified health centers and rural health centers, they recently gave passage to legislation that has said, okay, they are allowed to be that distant site. So during this emergency period, they can bill for services. They can also provide extra nursing services with fewer requirements. Our Medicare Advantage programs can add, if you will, to their policy benefits. Certainly CMS is going to encourage them to do that, but they don't have to do it. It is their choice to do it, and we just have to look on their websites to figure it out. So here's an example. If I went out to the Aetna website, and here's an example of what Aetna would say on what they're doing. And so there's all this instruction and there's all this instruction. That's for one insurance. And there's all these different variables. You can see we've got copay information, we've got modifier information, we've got cost sharing information, care not limited to COVID-19. So that means the diagnosis isn't an issue. Reimbursement will be made for two-way real-time audiovisual interaction. So that means we're going to have both. You can't just do phone calls if we're going to use what they're calling these telehealth services. Use telehealth as your first line of defense, meaning don't go into the office, try to use this. So this is just Aetna, and that's all the variables that they have. And the problem we have is every single insurance can have those variables in different places, if you will. If we look at definitions, this is for Blue Cross Blue Shield of Michigan. It says telehealth is an umbrella term that includes telemedicine, telephone, and online visits. I totally agree with that. Then down here it says telemedicine is the use of the telephone. No, you just said telemedicine up here is different than telephone. So there's that inner use of those two words of telemedicine and telehealth interchangeably that can certainly cause confusion. But for Blue Cross Blue Shield of Michigan, what they said on the next page is they said, we're going to follow Medicare. We've aligned our requirements with CMS prior to April 30th, and they're going to reevaluate after that. So the bottom line is Blue Cross Blue Shield of Michigan is saying they're following what CMS does. And this reference to this page talks about telecommunication and that it has to be that audio-visual capabilities. So that tells me what Blue Cross Blue Shield is allowing, but now I have to go back to figure out, well, do they want modifiers? Do they want place of service O2? And now here's more instructions. So unfortunately, what I'm saying is for each and every carrier, your staff has to figure this out. They have to go on the website and look it up and see, what does my Blue Cross Blue Shield of my state want? What does my state Medicaid want? Now, my suggestion might be to contact your medical societies or other local organizations, even local coding and billing organizations, for your staff to get the information they need so that they can disseminate it to you for who might allow for just telephone calls. But you can see it's getting into coding and billing, and you just want to take care of patients. So my suggestion is this, and I don't put it in writing because it is just my suggestion. Take care of your patients. Document consent in your record. Your ancillary staff, auxiliary staff can do that, that the patient knows the service they're getting and they may have copays. Try to do it with audio-visual as much as you can, but if you can't because grandma has a flip phone, if you can't because grandma's computer doesn't have a camera, if you can't because grandma just can't handle the technology, document that you tried and document that you did the best that you could. Document the service that you did, the circumstances that you did, and then look at the 3 sets of codes that we have. And choose the code that you think best reflects what you did or tried to do. I'm not saying that you can or can't do certain codes one way or the other. We are still in the discovery phase, and if you can hold on to these telemedicine claims for another couple of weeks till some more information shakes out, maybe we'll be in a different scenario and be giving you different information. If you can't and you have to file them, you're going to be appealing for certain amounts of money. Who knows, is that something that your practice can handle? The difference between a 99213 and a mid-level telephone call is twice the amount of money. So if you use the 99442 as opposed to a 99213, you're getting half the money. So document your good faith efforts and hold on to the claims if you can to see if we can get clarification so that they're allowing, when you can't do the technology piece as much as the code is asking for, but you made good faith efforts, that will that be good enough? And we don't know the answers to those questions. So I've given you all the information on all of the codes. So when you're starting out on a more routine patient, you know what codes are available to you. Are we doing email? Are we doing patient portal? There are some patient portals that allow for you to do audio visual. And so now that goes into more of a telemedicine office visit. You have to understand the differences in the codes, and then your staff has to figure out how to bill for it. So it's a collaborative effort more than ever before. I've tried to give you some information regarding for 2020, what the codes are and what the RVUs are, just because I get this question a lot. So that's the information that I put on these slides. The AMA has, this is information off their website for the codes. And then this slide, which the red disappeared, the red is supposed to be there because these codes are stated as payable. They're just not listed on the fee schedule yet. And boy, that needs to be all red. and it's not. We have our online digital visits, and the difference between these codes, the 98970 to 72, and these G codes is Medicare doesn't like the word evaluation and management. They want assessment and management, and so they're trying to get that changed around. This website has a ton of good information, both for providers and coders and billers. They are coordinating current information as best they can from what I can see as I visit this website. So if you're looking for a place to go to find something that might give you more information, I'd suggest going to the ccpca.org website. This guide was fantastic until the last set of rules came up and it became outdated. And then there's actually a CMS current emergency website. This website has tons of information. You can go, let's see, where is it? Hold on just one second. There's waiver information. There is, I'm looking for something in particular. No, it's on one of the other websites that says waivers. There's information regarding teaching hospitals and interaction with your residents, the level of supervision you provide to your residents, and just think of your residents and the level of supervision you provide to them as being the same as what we talked about supervision to your staff and your NPs and PAs. You can do it through your technology in most instances. There's a couple of restrictions, endoscopy and stuff, but there's a whole document on physicians and resident care. And there's documents about several other situations, and those are found, let me just get back up here. That's what I was looking for, is the one that says it's on waivers. It's a whole section on waivers. But all of these documents are the press releases you've seen. You can see they're colored because I've gone back and forth and gone on them over and over again. Trying to stay up to date with some of this information it can be overwhelming, but we're doing the best job we can to get the information out to you. Now we're going to do questions in just a second, but we also have some resources that the AOA has out there for you.
All right.
There we go.
All right. Thank you, Jill. While we're going over these next few slides, if you have questions, type them into the Q&A box, and then we'll start reading them. The AOA resources on the COVID-19, that's the link to the AOA page that is updated as soon as we get more information. It's constantly being updated. Then we've got the AOIA webinars. We have another one with Jill on Thursday night, so if you haven't registered for that yet, you may want to register for that. And also let your coders or billers know, because that's when she's going to go over a lot more of the coding and billing. And then the next slide, telemedicine platforms. And we actually had a question regarding this, if we were recommending any. And the AOA has have two that we are looking at that we're recommending that we vetted. That is Cirrus Health. And then that's for remote monitoring, sorry. And then there's also the Bluestream Health. So those are two that the AOA has looked at and are out there, and they're working with our physicians. So you can find links to those on the osteopathic.org member value page, or when you look at these slides, you'll find that again. And then the next slide basically has just Physician Services Department at the AOA if you have any questions, and then also the way to reach out to Jill. And now we will go to our questions. So what is the correct CPT code to use for skilled nursing facility telemedicine consult? 1, over the phone, 2, using video and audio, and 3, what place of service code modifier should we use? 02?
All right, so if we're talking telemedicine, you have to look at, I got to say this the right way, let me see. If you're doing a consult that would normally be done in the skilled nursing facility, what CPT code is that to you? And then go to the list of telemedicine allowed codes for telemedicine. So it's not that you change the CPT code necessarily, more you look at what would I normally bill and is that on the list? And I apologize, I don't know the codes for skilled nursing facility off the top of my head, if it's a regular consult code or not, but that's what you have to look at first. Now, if it's just over the phone, as opposed to trying to do it telemedicine with the audio and video, then if it's just over the phone, then it's probably going to be one of those over the phone, the 99441 codes, 99441 to 443. And if we're talking to Medicare, we're not using place of service 02, because remember, if we use place of service 02, you're going to hit up against that facility differential in payment. So you're probably going to use, and they don't say to use office, they say use the location you would normally use for that service. So it may well be that you're using a code and you may be using skilled nursing facility as the place of service, but it depends on what is the CPT code that you're providing the service for. And that's something that the coders and billers will talk about that a little more extensively. I know I'm asking you to look something up on a database, and that's probably not fair to ask a provider to do. But provide the service and then talk to your coders and billers and say, okay, normally I'd bill this code. Is this code on the list? And then take it from there.
Okay. And before I go to the next codes, those of you that have raised your hand, you have to type your question into the Q&A. We are not going to take live questions. So next question, what about patients in rural or indigent areas that cannot use the audio visual but can talk on the phone? How do you handle that situation?
That is the comments that I made just a moment ago. If you know that you can only have a telephone conversation with a patient because they don't have the visual capabilities, your only official remedy is to use the telephone codes, which would be the 99441 series or the G2012. I think, again, we talked about good faith efforts, and I don't know the answer to that question if that's gonna fly. So I would say provide the service to your patient, document the situation, and maybe hold on to that charge for a couple weeks and see if we get a better clarification, because I just, in my heart of hearts, I don't think that the person that wrote the final document realized we're talking people over the age of 65. We're talking about people that don't have a technology base of information and may not have the technology tools that they need. So I'm certainly hoping that they're going to reconsider and perhaps make an allowance either to increase reimbursement of the 99441 to 443 or to relax the visual component if, again, like you said, the patient just doesn't have that capability. Again, that's what we're hoping for. So holding on to those claims for a couple of weeks may be something to try for. Thanks, Cindy.
All right, next one. What is the best way to get consent since the patient is not in person?
Again, I looked at the rules, and the only thing that we see on consent right now is that auxiliary or ancillary staff can gain consent for you and document it in the record, but nowhere does it say what is the consent for. I've looked at some of the consent documents, and I am astounded at the amount of stuff that I'm assuming some lawyer put in, because to me, what you're consenting to is that you understand that this is going to count like a regular office visit, and that there's going to be a charge for it, and that you may have financial liability. Some of the consents talked about both the negatives and positives of being on the phone for the service, and I'm like, okay, that's going a little too far for me. So my recommendation, and that's why I say you have to have a policy, you have to kind of decide what do you think is important, because if you read certain documents, you'll have a lot of stuff. If you use your common sense and say, you know, I'm doing an office visit on the telephone. You know, if someone was doing this with my aging mother who's 88 years old, what would I hope that they would tell her so that she understands what's going on? And I think that's really, with a lot of this, we have to just look at what's common sense. So the answer to that is, you know, telling them that they know they're doing an office visit over the phone.
Yeah, and one of the things that came to mind, those of us that have been around for a long time, remember that what you used to do, if you needed to get consent from someone, you had someone else on the phone with you that heard them say it, and you documented it in the chart that way. So I don't know if that would fly, but that's how I remember doing it way back when.
Yes, I do too.
Okay, next question. Would you share with us the source of the place of service 11 with modifier 95 ruling, as his company tells us to use place of service 02 only without modifiers?
And again, that their advice to you was correct as of last week or early last week. The information comes from the final rule, and Cindy, if you remind me, I'll do that. I'll give you that document,
Okay.
a link to that document, but it's not place of service 11. It's the place of service where you normally would provide the service. That's the verbiage that they use. And it is in that document, that 1744 document. And where is it? And if you write down, sir, page, I think it's a sir, I can't tell. If you write down page 15, there's information on page 15 that will talk about how you're supposed to use the place of service. And again, this is for Medicare only. The next insurance, they want 02, and that's why if you're using a billing company, they have to be as on top of this as anything, because again, it's evolving from every insurance. Things are evolving. So thanks, Cindy.
Okay, and then the next one's asking for the Medicare hotline number, but I believe you provided that in a slide. So we're gonna leave that one. And then what if the Medicare patient refuses to use the video component, but is willing to use the audio component? Can this still be a telehealth visit and billed accordingly, since we did offer both audio and video to patients?
And I'll say it as politely as I can, whether you offer it or whether they can't do it, technically speaking, it cannot be telehealth 99213 office visit, you know, using that number as an example, if you don't have both audio and video capabilities. The final rule did not give us a third. If you tried really hard, that counts too. And that's what I'm really, really hoping they're going to give us in the future. But as of right now, that's why I'm saying if you can possibly hold these claims for a couple of weeks so we can see if we can get some better direction for we did try really hard, or in your case, the patient refused, to see if that would allow us to qualify for the code, because the reimbursement differential is so significant. So the answer is we don't have an answer right now. That would have to be billed today as a telephone call only, even though you tried.
All right. You mentioned the complaint of an earache. If we have a telemed visit with a patient for this, and this leads to a recommendation for an in-person office visit for an ear exam, can we bill a full office visit for both interactions?
It depends on what code you're using. So if you're doing a 99213 audio visual, and you're then asking the patient to come in the office to do a 99213, again, the medical necessity of that, you're going to have to be very careful at the level of service you're looking at. I can certainly see a scenario, because I've worked ENT, where that could happen. Using the telemedicine codes, the office visit codes, they don't have that 7-day restriction, you know, having to do with an E&M 7 days before, or a service in the next 24 hours or next available appointment. The office visit telemedicine codes do not have that restriction, nor are there any frequency restrictions that we have seen. So the only thing you have to worry about is medical necessity of both visits. Okay. Thanks, Cindy.
Mm-hmm. Does the video sent to me by a patient, example, walking with a walker, have to be embedded into my medical record? I still have paper records to qualify for a G 2010.
Well, it's supposed to be sent to you by secure. It's supposed to be kept in a secure environment. Boy, that's a tough question, because I don't. I think about 7 years of keeping it in a secure file on a computer. I don't have a good answer to that one. That's a great question. I would say yes, you should always keep a copy of it, especially if it is significant in your diagnosis and treatment of that patient. But I don't have anything to back it up. So whether you put it on a jump drive or a CD and throw it in the patient's paper record, that's about the best I could come up with. I'm sorry, I don't have a really good answer for that, but that's a great question.
Okay. How much documentation is required for the online digital management services? Does it need to include history, assessment, and plan?
I knew somebody was going to ask this question. We see evaluation and management services. We see that phrase in the code. And so to me, it says it needs to sort of look like and act like the duck, as we say, that it is. We don't have any specific regulations on how many bullet points we need. We don't have any regs on what the medical decision-making level has to be. And yet they do call it an evaluation and management service. So my best answer would be, you need to include what you need to show the medical necessity of the visit, and document what you feel is pertinent to that visit and the decision-making you have. Make it look like an E&M service, so that could be in a narrative form, but show that evaluation of the patient and then the management portion of what you're doing, but without any bullet point regulations or restrictions that we've been made aware of at all.
Okay. The next one is referencing slide 24. And it says, for resident physicians, we do not bill time for resident time-based reserved for participation of attending only. Should we have them code based on medical decision-making and not time for audio-visual communications with direct supervision of preceptors?
All right, let's see. I know that that is probably going to be found in that document that is for teaching physicians. And if you'll hold on to that question, and while we go to the next question, I'm going to see if I can do two things at once. I have two binders full of information, and I'm pretty sure I have that document for teaching physicians, because I don't know that answer off the top of my head.
Okay.
And if not, if you find that document for teaching physicians, that's where the answer is. But let me see if I can find it while we're doing other questions.
Okay. And then it says, now Blue Cross Blue Shield is allowing telephone call only without video. What are codes?
All right. So, and I'm looking at the questions too. So we need, that is in your state. So if they're saying they are, and you've got to be very careful, because I know in Michigan we had a huge misinterpretation of the rules, because the way Blue Cross Blue Shield worded things, it led people to believe that because it says Blue Shield is allowing telephone calls for telemedicine. Well, remember we said telemedicine, telehealth? They're allowing telephone calls as in the 99441 code. Are they allowing telemedicine, which is the 99213, 214, 215 codes without video? That's the question that has to be asked. And that would be for your state's Blue Cross Blue Shield, which could be very different than mine. I can tell you in Michigan, they are not allowing telephone calls only for the 9921314s. So.
And I think we're seeing that a lot of people are interpreting things differently on that, but I know I wouldn't take a chance. I'd want it to know specifically. Okay, can a certified ophthalmic medical tech take a call from a patient and bill as a 98966 7 or 8 code?
I would say go to the CPT book, and there is extensive guidelines for that, and see if there are any contraindications. I apologize, I'm not familiar with certified ophthalmic text, but look and see if in the guidelines, just before the codes, if there's any restrictions. And if there isn't, give it a try. But I can't give better advice than that because I'm just not familiar with that provider type.
Okay. Can you clarify, did you say that once a rule, that there was once a rule that physicians had to be in the office to perform telemedicine services, and this is no longer required?
Previously, and I got to say this the right way, because we were told that physicians had to register if they were at home doing telemedicine services, told us that that must have been a rule that was in place previously because that rule got waived. So I don't know if that makes backwards logic, but the information that we found for telemedicine services talked about you needed to register the physician's home office if they were providing services at home in their PACOS file. And then later on they said, no, you don't have to do that under the waiver. So that told us that there must have been a rule, because many of us don't work with telemedicine before this. There must have been a rule in place that said the place of service that goes in box 32 on the claim form is the place of service that the physician was at. So that appeared to have been in place previously, but the bottom line is right now it's waived, so it doesn't matter.
Okay. If I am opted out of Medicare and do not take insurance, patient directly pays, but I give the patient the super bill to file their own claim. Are these guidelines still the same, or does that not necessarily apply?
I do not know. I have not seen anything that has addressed physicians that have opted out of Medicare. Part of me doesn't see why it would change.
Okay. And this is just a thank you for providing the teaching hospital waiver link. And then next one, what if patient is sick and I have phone call appointment with them several times with a span of 2 weeks?
Okay, what if it, and I have phone call? We have not seen frequency limitations on these codes unless the code itself talks about it. So it says, what if patient's sick and I have a phone call appointment with them several times in a span of 2 weeks? So the first time you have a phone call E&M with them, that's a new problem. But then the next time you go to have that phone call E&M, it has to do with the other phone call that you just had. And so to me, that might butt up against a frequency there, if that makes any sense. We know if you try to tell them to come into the office within the next appointment, that's not going to work because the code says you can't do that. So I guess my question would be, is it that the patient's sick and you're checking on them? Or is it rather that the patient is having new problems that need to be addressed? I think I would be a little more forgiving if it were presented as perhaps new problems of an evolving illness, where we could say, well, this isn't just about the last E&M, something's changed. It's all going to be in the documentation. And if I haven't said it, you know, document the heck out of what's going on with your patient, how sick are they, you know, these new signs and symptoms. Don't make an assumption. Assume that someone reading that record, if it were ever looked at with a critical eye, that they would be able to see exactly what happened with that patient. So for the answer, if you're seeing that patient, if you're having conversations with that patient because they're continuing to evolve in their illness, document that. But we don't have frequency limitations on billing the codes over and over again. But remember, in the description of the codes, like the 99441 codes, they're saying you can't do them within certain timelines. So, thank you, Cindy.
Can you charge for review of labs with a patient by phone when a new diagnosis, we list only diagnosis or also the Z codes?
There is a couple of the codes that specifically say they are not for review of labs. And to me, there's two ways to look at review of labs. There's the, you know, Jill, I got your CBC back and your cholesterol's up, so you need to continue on your medicine. And then there's the, Jill, I got your labs back and several of your values are up. We need to talk about putting you on a new medicine, and we need to talk about some lifestyle changes. So one is a perfunctory call and the other is more of an evaluation and management code. So can you charge for a review of labs? It depends on if you're providing a true E&M type service, where you are evaluating the patient, making definitive management decisions like we would see if you were to document a bullet pointed E&M. I think you have to be very careful with those lab codes, just like with your Coumadin checks and stuff like that, where are you really doing any work or is it just a perfunctory checkoff? Thanks, Cindy.
Okay. What if patient has a scheduled appointment having to do with medication, say for hypertension? Can I change this into a telemedicine telephone call?
I think that is the perfect example of what they want you to do. We want that patient to have an evaluation because they're hypertensive. We want to see how they're doing. Do we need to refill their medications, change their medications, make sure they don't have any other problems? Absolutely. I think that is the definition of a telemedicine audiovisual service, a 992-13214, or if you can't get the visual part, then just a telephone call. But certainly the patient has a problem. And so that's the, you know, the problem is their hypertension and we need to follow that.
Okay. Is it okay to see patients via telemedicine to follow up on chronic illnesses such as diabetes and hypertension and annual exams? My patients are still getting their labs done for these office visits in a very controlled and safe environment and then following up with me via telemedicine. I feel like we still need to cover these problems because we do not know how long we will be like this.
Absolutely. So if, you know, your patients are having labs and you're doing sort of routine follow-up office visits via telemedicine, keeping them safe and at home, that's exactly what it's designed for. Regarding annual visits, are the codes that you're using for the visits, are they on the list of approved telemedicine codes? I happen to know that AWV is on the list that you can do. So again, you have to look at, can I do these codes? Are they on the list? Understand they just expanded that list. Can we do this with the audiovisual communications technology? Now, the next question that somebody's going to ask is, well, wait a minute, if you're talking an AWV, don't you have to take vitals? Kind of hard to take vitals over the phone. But if they have any information that they can give you, document what you can get. And I think that you're making that good faith effort. We'd much rather have that visit done than not done. And even if you have the patient take their own pulse and write that information down and write down that they got on the scale today. Again, good faith effort to get the best information that we can.
Okay.
So yes, continue to take care of your patients.
Right. Using my EHR for a visit, what code would I use? Using FaceTime, what code would I use?
I have no idea because I don't know how you use your EHR for a visit. You have to look at, are you providing a visit via audio visual, just audio, or are you doing it via email? I don't have enough information, I'm sorry, to answer your question. And using FaceTime, I will assume you're trying to do a telemedicine visit, like the 992-1314 office visits that we talked about at the beginning of the presentation. That's the best answer I have. I'm sorry, I just don't have enough information.
Okay. And are we able to use non-physician codes for RN or LPN or MA office staff spend time?
Good try, but unfortunately, no. They have to be licensed and they have to have billing capabilities. So all the time your staff is spending trying to set up a telemedicine visit with grandma on her flip phone is unfortunately not billable time.
Okay. Is there a sample consent form or template you recommend?
No, not at all. Remember, I said the ones that I looked at, I mean, it pretty much was terrible things can happen to you while you're on this telephone call kind of thing. I thought the consent forms that I could find copies of were not good. I haven't found a good one yet, but I've only recently started looking. So I would say from a consent perspective, just what would you want, you know, your patient to know for sure in the form of consent, and put that in your policy manual.
Okay. A patient sends me a video via text. Does that work?
I think the secure environment that we're supposed to have has been thrown out the window. Certainly, they're sending you the technology piece that the code describes. How you get a copy of that into the record? Boy, that would be a good one. I guess you'd have to save it and then email it to yourself off your phone to be able to save it into a document, into a format that you could put in a patient's chart. But again, if you think of a lot of the restrictions we have that were intended to keep good quality care have been rescinded in order to allow for good care during a crisis. So normally, if this was a normal environment, I would say no, that's not the way you should be receiving stuff. But in this environment, I'd say it's probably okay. Just again, because they've lifted so many of the restrictions.
Okay. Do the same rules of parental or guardian consent for seeing minors apply in telemedicine?
I would absolutely think so, yes.
Okay. What about calls that just want to get tested for COVID-19, or they want a work not to be quarantined? I want a not work letter.
That has, yeah. The people that just want to get tested, you got to have an office policy for how you're going to handle that, because that's a call your staff could take and get you good information. And those that want to work and don't want to be quarantined, again, that's an office policy regarding a form that you need. So those are not, I don't see those as billable instances.
Okay. Sometime when using FaceTime, *67 does not work. Then they call or text me all day long. What's a good way to tell them to stop?
Well, let's see. From a tech perspective, I would say you can always block a phone. And the other thing is also to block your format before you make the call, or get a burner phone for the office so that the office has its own phone, so that they don't have your text number. I know it's a problem I'm hearing more and more about from doctors, but there are settings on your phone to show that it'll say no caller ID when you call them, so that they don't have your cell phone. Otherwise, I would say go into your features and see if you can't block that phone number, which I'm sorry to say is terrible, but I would say send them a text and say, you know, say something that tells them that you're blocking them.
Okay, and looks like the last question I believe you've already answered, but if a patient calls in with a new concern, the RN spends 5 minutes in a phone triage with that patient, then send to the provider who spends 3 minutes reviewing it and makes a treatment decision. Then the RN calls the patient back and spends another 5 minutes on the phone reviewing the plan. Are there any codes to bill for this time spent?
Nope. Let me just see if I can be creative here. Hold on. Yeah, I mean, the patient, it does not appear that the provider has any interaction with the patient at all.
Oh,
So,
yeah.
yeah, that's all I can, sorry about that.
Okay. All right. And then there was a question as to why not get an extra credit for CME through the question and answer. I will talk to the AOA CME department, and if it turns out that they're going to approve it, I certainly will make sure that you all get it. So I will look into that. And I think that covers it. So hope to see you all on Thursday as we as Jill joins us again. So thank you all for being here, and stay safe. Thank you, Jill. Great information.
Thank you all. Good night.
Good night.